Hi, this is Long. Welcome to our video series on search patterns for the most common studies in radiology. Please note that this is an introduction to study interpretation. An enormous amount of detail is omitted for brevity. Continue dedicated reading, seeing as many cases as possible, and keep getting feedback from subspecialists during the course of your training. All right, guys, today we're going to talk about an approach to the MRI brain, one of the most common studies done in neuroradiology. So as usual, the way we're going to start is to get a sense of the indication, the patient context, and history leading up to the study. And then we're going to take a look at localizers and then sequence by sequence. In whatever order they're provided, we're going to go through each part of the anatomy. Typically, at our institution, we're provided first sagittal T1 pre-contrast, diffusion weighted images, susceptibility weighted images, and then some order of T2 and flare images. In different projections or planes, and then post-contrast T1 images via different techniques and planes. And we'll go through each of those in detail. All right, so when we do the background reading, figuring out what is happening with the patient and the study indication, we want to get a sense of is there a known abnormality? Is there a primary brain malignancy? Is there an underlying malignancy somewhere? In certain cases, you're going to want to know, like, what is the pathology of any known brain tumor, how's the patient presenting? All this background information is going to inform how you take a look at the exam. The way I'm going to take you through this search pattern is as if there is either no known abnormality, or we are looking for something new. Frequently, what you can do in an approach to a patient who already has a known abnormality is take a quick look at that first, evaluate that and its positives and negatives, and then come back and just make sure you're missing nothing else. But we're going to do this as if we are searching out in all of the anatomy a potential explanatory pathology. Okay, so first we're going to take a look at the sagittal T1s, which are presented first. And from an outside-in approach, I like to first take a look at the subcutaneous tissues, the calvarium, and take a look at the marrow signal, particularly in the calvarium, skull base, upper visualized cervical spine. You'll also notice that you see a lot of the facial soft tissues, and we're going to take just a quick look at the orbits, facial soft tissues, upper neck, and then basically all of the extracranial soft tissues from the ears, parotid glands, from one side to another. Okay, we'll take a quick look through the cerebral hemispheres just to get an overall sense of the anatomy, any sort of anatomic distortion. And then the major point we want to stop is at the midline sagittal. We're going to look in kind of this triangular region at the pituitary, cellular, suprasellar region, the pineal region, and then the skull base of the foramen magnum. We're looking for mass lesions, cystic structures, any sort of like mass effect in these areas, and then particularly here low-lying cerebellar tonsils, any sort of herniation or other abnormalities of the skull base, and also making sure we don't miss any sort of abnormalities of the incidentally imaged upper cervical spine. Okay, and then we're going to come back to that area, particularly on the post-contrast T1s. The next set of images we're provided is typically diffusion weight images. This is the B0. You may recall that the B0 image can be used as a quote-unquote poor man's SWY. So if we scroll through, and I typically like to use an outside-in approach, taking like the extracranial soft tissues, CSF spaces, and then lobe by lobe in the brain, supratentorially and infratentorially, taking a very quick look for any abnormal susceptibility, even though we will eventually take a look at that on the susceptibility weighted images as well. You'll note that this is kind of like a T2, has like an appearance of a T2 weighted image. Finally, taking a look at the higher B value diffusion weighted images. Similar, we're going to do an outside-in approach, noticing that outside the brain you can find lymph nodes, other sort of abnormal soft tissue abnormalities, which will show diffusion restriction, and kind of doing extracranial soft tissues, the calvarium. Sometimes you will pick up calvarial lesions, up and down, taking a look at the incidentally imaged upper neck, and then making sure you look at the extracranial soft, the extraparenchymal CSF spaces, and then lobe by lobe through the brain slowly, frontal lobe, parietal, temporal, into the occipital, down to the posterior fossa. And it's important, especially in the setting of suspected subtle ischemia, to go slice by slice and be very careful to look for any sort of subtle abnormality. Okay, the next set of images is going to be the ADC, which are going to correlate, side by side with your DWI to see that if any abnormality, DWI signal, has a true corresponding ADC signal loss or low ADC value to see if that's true restricted diffusion or T2 shine through. So we're going to go back to the single stack. The next set of images is going to be our axial flare. And flare, we're going to do a complete search pattern through the extracranial and intracranial anatomy, again covering the extracranial soft tissues, orbits, everything. Calvarium, you will pick up calvarial lesions, and then similarly through the CSF spaces, including the sulci, ventricular system, basal cisterns, and then through the lobes of the brain. We're kind of going through in a big picture approach here, but the flare, I'll let you know, is going to be your major workhorse sequence to detect and characterize parenchymal signal abnormalities. It's going to give you a good look at the anatomy as well for midline shift, mass effect, all these sorts of things. And we're going to come back to flare in different projections. Okay, here we have a time of flight sequence, which we'll discuss more thoroughly in a different video. So we'll just move now to the coronal flare. You have to note that the coronal and axial flares, because they're required separately and are not reconstructions of one another, actually will image differing amounts of anatomy. So you can notice that on the coronal flare, you actually see more of the upper neck than you see on the axial flare, which only goes down so far. And so particularly on the coronal flare, we have to be very careful to not miss any sort of incidental lesions in the upper neck. Coronal flare is particularly good also for extracranial soft tissues, calvarium, and abnormal pachymeningeal, leptomeningeal, or CSF space lesions. This can also be very helpful as troubleshooting to sort out any sort of abnormalities you saw in the axial flare that are not well characterized, or where you cannot see the full extent of its anatomic distribution. And again, major blind spots are typically this upper neck, extracranial soft tissues, and CSF space. People generally will not forget to look at the brain or not forget to characterize lesions in the brain, but you have to remember to look at all the other structures as well. We're not going to move to the SWI, which is now presented after this flare. These are MINIPs. We're going to go now to kind of like the more thin. So these are SWI. And the only kind of thing here is, again, providing a generalized search pattern to the whole of the imaged anatomy. The major thing not to forget is to look at the CSF spaces, not miss subtle subarachnoid blood, subtle blooming around venous structures, and then again to do a full search pattern to the brain parenchyma throughout the lobes, supratentorially and infratentorially. Okay. Here we have axial spin echo T1. So this corresponds to the sagittal sequence that is provided first, but the major kind of thing here is to, again, look at the extracranial soft tissues, look at those fat planes, especially in the upper neck. And this is particularly good to look for marrow placement in the calvarium. You know that T1 pre-contrast is going to be one of your best sequences to find marrow lesions. So you're going to do that both in the calvarium and the skull base, and also get a sense as to whether there is any inherent T1 signal abnormality for lesions or other findings in the intracranial compartment. And that's going to be something you compare to the post-contrast sequence to look for real post-contrast enhancement versus inherent T1 signal. All right, now we're moving to the T2 signal, the T2 sequence. Now this corresponds to our flare, right? We're going to have very similar characteristics for anything that has not been nulled out on the flare. So basically the T2 being complementary, I typically don't spend a lot of additional time looking at the brain parenchyma and things that are well demonstrated on the flare, but I'm going to put kind of like high yield places to look are the paranasal sinuses, the orbits. You're looking at fluid structures, looking for fluid in the master aerosols, and we just have to be very careful to remember that absence of signal does not necessarily mean absence of some sort of material, because high density secretions and other things will create absence of signal even on T2. We're going to also use T2 to look at the CSF spaces, doing quickly through those. You look for vessel flow voids, particularly in the large central arterial vasculature around the circle of Willis, and inclusive of the posterior circulation as well. And again, looking within major CSF spaces you can find more subtle extraaxial collections, mass effect on the T2 weighted sequence. Okay. And now we've come to kind of one of the highest yield, along with the flare sequences, to look for pathology. And we've got here thin, or rather 3D isotropic post-contrast T1. This is a GRE sequence. You can notice that the calvarium is a little bit darker, with like a slight kind of signal loss related to the gradient echo technique. And so basically, to not get too much into the weeds, especially for the this is going to be provided sometimes in multiple reconstructions, as we have here, even though this is these three, the coronal, sagittal, and axials, are actually acquired as a single volumetric data set. We're going to approach this with a complete search pattern through entirely the extracranial soft tissues, scalp, orbits, upper neck, basically going through that entire anatomy and being very careful to look for any subtle enhancing lesions. Okay, this is going to be frequently one of your higher resolution and higher signal to noise, and especially with post-contrast enhancement, more sensitivity for serious pathology. Going through the extracranial soft tissues, osseous structures, and then ultimately looking through your CSF spaces, and then ultimately vessels, making sure that you are, and now I've mipped up these images, making sure you take a quick look at the vascular structures for incidental aneurysms, incidental, let's do this, thrombosis or filling defects in the venous sinuses, and then I like to use the MIPS to look for small, subtle enhancing foci within the brain parenchyma, or also abnormal leptomeningeal, pachymeningeal enhancement. Okay, we're going to do that through each lobe of the brain, and then using each projection, such as the sagittals, is going to be particularly good for the skull base. We're going to return to the pituitary gland in the cellular suprasellar region for looking for abnormal enhancement or mass lesions there, particularly the skull base, looking in the pineal region as well, and just kind of sorting out points of anatomy such as in the face and upper neck that are better visualized on the sagittal projection, and then on the coronal, similarly looking at particular areas near the vertex, near the skull base, in the face, or kind of areas at the periphery of the intracranial compartment that are more difficult to sort out on the axial and sagittals. And we're going to, I'm going to go through quickly, but you're going to use that as a search through, as another look as needed to problem shoot any abnormal findings or difficult areas of anatomy. And here what we have, maybe acquired at some institutions, is a spin echo 2D acquisition post-contrast kind of T1. So you'll notice this is not a volumetric acquisition similar to the last sequence we went through, but this is actually acquired delayed relative to our MP range or our isotropic post-contrast. And because it is acquired with a differing technique and at a delayed time point, you will see enhancement on this sequence that is more conspicuous in lesions than on the other. There may be lesions that you only see on this axial, slightly more delayed, slightly different technique, post-contrast T1. So, similarly, we're going to do a full search pattern through the anatomy, which, I'll leave the details as I covered, and we're going to go through a full search pattern through the anatomy, extracranial, intracranial, and then through the brain parenchyma. Okay, we'll go over the MRI images, and then we have localizer images here, and you'll notice sometimes you kind of see a little bit more of the upper neck than seen on the remaining sequences. But just to go through these quickly and make sure that we don't incidentally see parts of anatomy that we don't see on other sequences and miss some sort of serious mass lesion or severe kind of stenoses or other pathology in the upper neck that we don't see on other sequences. And so that basically covers the approach to the MRI, brain pre and post contrast. Major things to think about are just to make sure that if you have found abnormality or have not found abnormality, to see if that's concordant with the provided indication and patient history, and particularly for any sort of known abnormality on prior studies, and then anything you find in any one sequence, it's very important to correlate that across the various sequences to see what its signal characteristics are going to be like across the different imaging MRI sequences, and that will help you come to a more fine distinction as to what pathology you're looking at. And so just as a quick review, on the MRI brain, you're going to get a sense of where the patient is at, what clinical scenario leads to the imaging exam, and of course taking lab priors as necessary across different modalities. We're going to go through each sequence as they're provided, and then being very careful to look throughout the entire anatomy and using which projection or reconstruction is most advantageous to find pathology in different parts of anatomy, and correlating ultimately between each of these to find out really what's going on, in addition to correlating with the clinical history and prior studies.